All right. Good morning, everyone. This is Dr. Earl Stephenson Jr., your Atlanta board certified plastic surgeon, and welcome back to Plastic Surgery TNA. That's Talking Advice. I appreciate anyone who's returning. Thank you so much for your support. If you are new to the channel, I would like you to do a couple of things. I will welcome you first, of course, but please like, subscribe, and share. I'm really happy to have a guest. I hate to hear myself talking, so I love to have guests. And today we are honored to have Dr. Kris Day from Bellevue, Washington, Pacific Sound Plastic Surgery, and he is going to enlighten us today about gender affirming surgery. I have the privilege of knowing Kris for many years. I would definitely call him a colleague for sure, but I like to call him a friend as well. So it's going to be really interesting to have him on and talk to us about gender affirming surgery. But let me give you a little bit of background about Dr. Day's extensive experience. He went to Tulane as an undergraduate. He then went to medical school at the University of Iowa. I then transitioned into a general surgery training program at Brown University. He did plastic surgery, where we did plastic surgery, not together, but kind of separated about a couple of years at Erlanger Medical Center in Chattanooga, Tennessee. And then he finally finished up, I will say, with training in craniofacial surgery at the University of Texas at Austin. And so with that extensive background, Dr. Day is going to enlighten us about his journey and his practice of gender affirming surgery. Dr. Day, thank you so much for your time and welcome to Plastic Surgery TNA.
Yeah, thank you, Earl. It's a pleasure to be here. I respect what you're doing. You put out a lot of good information. You give a very honest account of stuff to people. So I'm honored to be part of it. Thank you.
Thank you. I really appreciate that, Kris. We really try to just kind of, like I said, try to give an honest account so people can get the information they need and make the decisions that are best for them. So,
yeah, for sure.
With that being said, I'm here in Atlanta. You're in Seattle, big metropolitan areas. And here in Atlanta, gender affirming surgery has certainly evolved in my 20 years here of practice. I don't participate in that. I don't have the training or the expertise that you have in that. But certainly there is a population here in Atlanta and obviously in Seattle that they're looking for these types of procedures. And so, with that being said, I know, and I can speak, and you can correct me if I'm wrong, from our base training at Erlanger, we didn't get that training either, per se. So, what was your particular journey to this realm of surgery?
Yeah, and I'll be very authentic about it. I don't only do gender affirming surgery, but gender affirming surgery is something that plastic surgery lends itself well to because we're such a malleable field where we're, plasticos is the word that the plastic surgery comes from, which basically means being flexible and solving problems. So we're a principle-based field. These are principle-based problems. So I think that's why plastic surgeons have embraced it because we have
Sure.
the skill sets where we can. But you're right. I mean, to be very authentic about it, it was if not not only not involved in a lot of training programs, including my own, but I think discouraged at the time when I was going through training. So I remember some conversations at the scrub sink before cases with the chairman of we don't do that here,
Right. Yes.
And that's just the reality of it. But that story is not unique. I have multiple friends that are chairmen of gender affirming programs at state sponsored multidisciplinary organizations that had no training no direct training to gender affirmation.
Sure.
Now, for those that don't appreciate this as easily as you and I do, it's a transferable skill set. So when you put together 1,000 people's faces after a traumatic events, or you have hundreds of reconstructions after a congenital malformation inborn in the face and the cranium, when you have repaired, very fine detail lip malformations across, the country and across the world, all of a sudden you find yourself in a situation where then if there's a large population of people who need something for which those skills can be applied, then there you are. And
Absolutely.
that's kind of how it found me. So
Gotcha.
Yeah.
Gotcha. I agree with that. I mean, to boil it down, I look at it a little bit like being a chef. You get a basket of stuff because we're, like you said, we're principle based and we have foundations of training, and we can make those applicable across many solution problems. And so, when you get a basket like with that, what is that name of that particular HGTV or whatever. It's basically you have a basket of stuff and you can take a basket of stuff and you can make a full meal out of it as opposed to being a cook where you have to follow a recipe. So I
Yeah.
definitely agree with that. So with that being said, I mean, what was a pivotal moment when you found yourself maybe with a case that presented to you? What was a pivotal moment in your commitment to continuing this type of service in your practice?
Well, it's a very practical but kind of boring story to that. I was an assistant professor at a university where the chief of the section retired, who was doing a lot of this, and I was told, "You're going to do this now." And I
Oh,
said,
okay.
"Oh, okay, yeah, no, that's
Where are you
exactly what I said."
from?
Yeah,
Right.
that's exactly what I said. I said, "Oh, okay." And then, I took a couple courses in basically sensitivity training to this thing that
Interesting.
both in a professional and a personal
Sure.
reference point, I didn't have a lot of easy reference to. And then I just discovered, really fortuitously, that this was a very invested patient population, and that's the common thread for
Yeah.
me, at least.
Okay.
I mean, it's why I went into healthcare, I feel, was, feeling that purpose and making those differences. And why I went into plastic surgery was to be able to participate in real transformational experiences with people. And I find that very fulfilling. And I find that whether it's a post bariatric body contouring patient or a post traumatic reconstruction or a post cancer reconstruction, or even a very invested aesthetic patient, if a patient is invested and committed and participating in their care, then that's easy for me.
Yes.
And so that's what the LGBTQ community has been almost to a patient. There's
Sure.
very few patients that are not very invested in their care.
That's interesting. Yeah, that's a great point. That's a really great point. Not to say that other segments of our patient base is not invested, but I can really see them really leaning into it to use that kind of terminology because I feel probably there are very few practitioners that they feel comfortable with going to, and when they find someone who can champion, if I could use that term, their cause, there certainly will be a motivated, probably a more motivated type of patient than maybe our typical patient.
Mm.
So, with that being said, man, so talk to us a little bit about kind of the nuts and bolts. I mean, what kind of procedures can people who are interested in this have, and break that down for us if you could.
Sure. So, gender affirmation surgery refers to basically any procedure that an individual with gender dysphoria, which is a DSM-5 recognized psychological condition, it's basically a stressor that
Interesting.
is a result of a person's disconnect with how they're identified as it relates to their gender and how they feel that they identify as it relates to their gender. So
Okay.
anything that brings those things into greater alignment with their physical structure and appearance would be considered then gender affirming surgery. This can involve the face, it can involve the breast tissue or chest, it can involve the body and its contouring, and it can involve bottom surgery. So
Gotcha.
bottom surgery refers to genital modification, which is the only part of that I actually do not do. But I had that subspecialization, as you noted, in craniofacial surgery. So I do all types of facial modification, which would include rhinoplasty or nose job, a reduction of the forehead, the glabella area,
Okay.
reduction of the jaw, augmentation of various features, which is more in your female to male transition, typically with custom implants to the face and other things such as lip lift, tracheal shave, fat grafting to the face. There's really a spectrum of
Okay.
procedures.
Sure.
Then to the breast, there's removal of breast tissue. such as double incision, simple mastectomy, breast reductions, or augmentation in in male to female transition with augmentation mammoplasty. And then body modification, you can basically summarize it as changing a rectangular form into more of an S curve, or
Okay.
changing an S curve into more of a rectangular form, depending on which direction that patient is trying to go.
Gotcha. Great, great. A question for me. I mean, this is great. This is why I like to talk to other plastic surgeons, because we know the nuances, and I can ask you some questions honestly as a plastic surgeon. Let's talk a little bit about you said this has basically an ICD-10 or an insurance code diagnosis potentially attached to it.
Mm.
Um, our first question would be: are these procedures covered by insurance? And if they are, how readily and how willing are the insurance companies to actually to cover these procedures?
Yeah, I can only speak to our individual experience with, dozens or maybe hundreds of patients, but I think it's going to vary in various practices. It's going to vary in various states. It's going to vary in all different types of insurance providers, and also in the area of the body that you're changing. So between the three that I do, face, breast, and body, in our experience, chest or breast is almost 100% covered.
Okay.
Face is probably more on the order of 50 to 75%.
Okay.
Body modifications is probably around that 50% mark or more, slightly more, maybe 50, 60%. And these are just off the top of my head,
Sure.
gestalt impressions.
Sure.
So yes, there is a diagnosis. It is recognized as a psychological disorder, being
Correct.
gender dysphoria. So, in the introduction book that I picked up as a medical student before I'd even been exposed to plastic surgery, the first page of the booklet that
Okay.
got handed out to medical students by the American Society of Plastic Surgery
Okay.
was, basically, welcome to your exploration of this exciting field of plastic surgery, the only surgery that operates on the mind. And so I think
Interesting.
this is a direct application of
Yeah,
that,
I
really,
agree. That's a
because yeah, some of the patients are even suicidal due to their gender dysphoria. So in some patients, I think they see this as um, change my appearance or don't want to go on living. So that's where I think it really solidifies the diagnosis. And
gotcha.
not everyone has that degree of dysphoria, but there
Sure.
are some with that degree of dysphoria. So it is a ICD-10 diagnosis by the American Medical Association.
Gotcha. So that's great information for our guests that are listening and who may have to ask that question. And what I hear from you is that yes, it's possible that it can be covered because it's a diagnosis of gender dysphoria. You have to check with your particular practitioner, your particular insurance carrier, and the geographic area that you're in.
For
That's
sure. And I hear all kinds of stories. I don't know, and since we're like kind of reaching out from Seattle to Atlanta here, yeah, and I did my training in partially in Tennessee, so I'm familiar and fond of the Southeast. A lot of good memories there.
right.
But I do have a lot of patients who have told me stories of, none of this is covered where I'm from, so I moved here. Seattle, I think it becomes a bit of a magnet for this type of care because of its degree of acceptance, or
Sure.
uh, you
Sure.
know.
I,
So
I
I do hear those stories quite a bit, and there's probably some truth to that.
I would agree with you. And then just as an overarching thing, I think the Pacific Northwest is seen more in a more accepting manner on many causes. So I think that's probably a true or nearly true statement. Um, Another question I had as a practitioner, and maybe you can just expound. You talked about you don't really kind of deal with the genital modification. And I think that from my understanding, you can confirm this because you're the expert. I think that requires an additional amount of training that neither you or I have. There are a few, I think, practitioners that have that training, probably a little bit more leaning toward of a gyno or urologic kind of focus in addition to plastic surgery? Could you speak to who, if someone is looking for genital modification, who they should be looking for and what credentials they should be looking for?
Yeah, that's going to be much more centralized in my perspective in a multidisciplinary tertiary referral center. Reason being is because you're starting to talk about microsurgery or free tissue transfer in most cases, at least in female to male transgender modification. So you're dealing with super specialized surgical techniques that you and I, have been exposed to and understand, but can appreciate. It's sort of like, hey, I'm going to play a Handel symphony with a collection of, side of the road, whoever has instruments, versus
Sure.
doing it in a symphony hall with, high end instrumentation. So I think that's where that difference is. You're talking about multiple days stays in the ICU for monitoring. You're also, to be frank, talking about 20% and above complication rates in the best of hands, in
Wow.
the people who write the textbooks.
Oh, wow.
Um, and that's just the reality of the current evolution of some of those procedures. So given its high degree of difficulty and its high rate of issues that have to be managed, and if you have a big team of people and you have a bunch of subspecialized, hey, I'm the Urogyne support social worker, right?
Sure.
In addition to 30 other people revolving around this, then that makes sense.
Yes.
For me, I know my limitations, and
I got you.
that's not one I can take on. However, we do a top surgery in 2 hours. I've had people after a 2-hour surgery going home that day, coming back within a week saying, thank you so much. I feel so much better about myself. So that's something that we can handle. And, we do pretty regularly. So
Right.
I think that's the difference though. Bottom surgery, there's different procedures too. So some of the male to female transition can be executed. And I have multiple colleagues with my similar training background and practice setup and things like that do some of the male to female transition procedures.
Okay.
But when it comes to like the creation of neogenitalia, it's pretty complex and should probably be done in someone who's doing that, and mostly that.
Sure, understood. So what I'm saying for the audience, or hearing from the audience, and to translate that, is basically you got to go to a big center that
Yeah,
has a team, and this is what they do all day, every day. And
yeah,
so walking into, and I'll just use my office, not to denigrate your office. If you walk into my office, you're not going to get that, and that's not the best place for you. So I got
yeah.
that.
Yeah, there's one guy in the state of Washington that I know that does that, and good for him because he's got a whole team around him. He also has, I'm told, a wait list out 2 years.
Oh wow, yeah,
So and then in California, I'm sure there's multiple. I'm sure there's some spectrum across your urban centers, such as
sure.
Atlanta and things like that. But
New York, DC, yes, absolutely.
yeah, it's gonna be a referral center, a tertiary referral center. I don't think that's necessary though. I mean, so some
Mhm.
people hear that and they think, oh, okay, I want to get everything right. I want to get facial modification in that setting. I want to get top surgery modification. I want to get body modification in that setting. I mean, a common skill set that every plastic surgeon has is liposuction. That's
Sure.
most of our body contouring is variations of liposuction. So I think it's rather, it's not a binary thing. It's not like, hey, everybody needs to go to a tertiary referral center, or everyone can go to anyone.
Sure.
I think in bottom surgery, probably it's a tertiary referral center. In everything else, though, it's based on your practitioner's experience. Body modification is probably going to be pretty accessible. Top surgery, I think, is usually pretty accessible. And I think, again, the reason that I'm kind of falling into this is just because I had that background training about facial modification that not everybody has done. So,
Agreed. Agreed. Talk to me a little bit about, you talked about people's health, mental state coming to you. How do you handle that? What's your protocol, your approach to someone who comes in and they want a procedure? they've been frustrated. They're really kind of at the edge, to use your term. Like, if I don't get this, I don't know if I can go on. How do you handle that patient?
Yeah, it is challenging. I once read well, not once, like just a couple months ago, I came across this article as I was looking something else up that described various practice risk, like what practices are most at risk of being in medical legal hot water. And
Sure.
it described a solo practitioner that was young who was dealing with patients with psychiatric comorbidities, and I just go, "Oh crap!"
Oh,
like, that's
right.
me. But I mean, so yeah, there don't get me wrong, there is an awareness and there's sort of a constant background anxiety to some of the anxiety. I mean, 100% of my gender dysphoria patients have anxiety and depression. I mean, I don't even have to review the data. It's one of my patients said that, I've got your normal run of the mill anxiety depression. She said they
Gotcha.
said it just like that. So we encounter that every day. And how do we deal with it? The best we can. How does
Okay.
anyone deal with anxiety? Anxiety and depression, I think, has been recognized through bestsellers to be epidemic and right now throughout the country. So that's just something that I guess I accept as a base expectation.
Okay.
After that, we utilize multidisciplinary approaches.
Okay.
So I participate in WPATH, which is the world organization that defines the standards of care for gender affirming surgery, and that involves the incorporation of a mental health specialist
Perfect.
and/or primary care
Perfect.
doctor who is orchestrating this, in addition to things like endocrinologists or pediatricians, if that applies, or other specialty providers that are engaged in the affirmation journey of these patients, and make it very clear that I am not that individual. I'm their surgeon. I'm not the psychiatrist. I'm
Right.
not the primary care doctor. And I'm not ultimately even guaranteeing or promising. You can't guarantee or promise any secondary gains in plastic surgery. So these things really have to be, one, assessed by an independent third party from me,
Right.
and have that documented, which is what WPATH asks us to do,
Okay.
and then have a real cognizant decision making on the behalf of the patient if this is right for them. And I'll stand by that, and I'll say that to very openly and directly to patients if they're in doubt. And we've had some that are in doubt. I had a patient who, as part of psychiatric comorbidities, sometimes there's substance abuse issues.
Sure.
um, we I find what's best is if a patient does attend with a support person their consult. So this patient attended with their mom.
Okay.
And this was a non-binary patient looking for removal of their breast, and in the consultation had brought up previous struggles with alcohol. And
Okay.
so I always ask a follow-up question if I get that, and say, is this still an issue for you? Has that stabilized, et cetera? Basically, they said, oh, no, no, I stopped. And then mom chimed in and said, yeah, you stopped after the bottle of wine you drank this morning.
Okay.
so,
All
so
right.
that situation took care of itself. I
Sure.
did not even have to make a decision. And if that patient wants to be seen again after they've gotten some things under control, then I'm happy to see them. But they sort of took themselves out after
Sure.
that exchange, and that's what I think is the right thing to do. I mean, if somebody isn't stable to make these decisions, then they shouldn't make decisions about forever modification of their body, and that's why we involve other people to weigh in on that.
Great. Perfect. It's good that you are accepting, your practice is accepting of kind of accountability partners to come in with them during the consultation.
Oh, yeah, I mean, that's usually the best. Now, sometimes that's backfired.
Yeah, of course. Of
We
course.
I've had the whole spectrum. I've had the whole spectrum. And I'm a parent myself, so I can relate, and to some degree, I'm empathetic to the challenge that must be involved in that. But
Sure.
yeah, ultimately it comes down to the patient though, and that's where we try to keep our focus. So that's whose wishes we're trying to follow.
Of course.
And but that support person is key, because surgery is a physical and emotional journey for anybody, no matter why
No
you're
doubt.
having it, you know?
No doubt.
So having those people is, I think, key to helping them make their own decision, but also getting through that process.
I totally agree, and I'll kind of broaden that from what we do kind of together, as plastic surgeons. No matter if somebody's coming in for a breast augmentation or tummy tuck or what have you, you've got to have the support system. It's not only a checklist of is this the good doctor, is or what are the complication rates, what's the pain, what are the costs. From our standpoint, we need to make sure that the patient has a good support system because this is a journey and there's a lot of kind of mental waxes and wanes during this journey, and you need to be there, or I think we should be there as practitioners and be empathetic to those hills and valleys and understand that. So I think that overall, overarching, plastic surgeons need to be checked in that there is actually a connection with mind and body.
Yeah, for sure. And I mean, I don't know how often you guys hear it in Atlanta, but here in the Pacific Northwest, there's a very strong theme of natural. And I can't tell you how many times outside of the gender affirming, but in the aesthetic consults, you refer to like tummy tucks and breast dogs. The question is, is this going to be a natural result, but is there going to be enough change, but is it going to be natural? So I mean, as surgeons, we're getting exposed to these things from a completely different behind the curtains perspective that allows us to translate some of those concepts in a hopefully sort of distilled down, unique to each patient, kind of meeting them where they are,
Sure.
useful degree of information. But at some level too, there's some trust in there, and it is relational. And I think when others that are patients who maybe have been thinking about a procedure for months or even years, and then they maybe like gone through a whole bunch to even be in the position to do it, then if they have some of those who have been there before that consult even happened, then it just makes so much sense because they're also the ones that are going to carry them through on the back end.
Sure. Absolutely. Absolutely. Let's pivot a little bit and maybe kind of be a little bit more nuanced. You talk about male to female and female to male. So I'm sure there are core baseline procedures that occur with a male to female and female to male. Expound a little bit more about the menu of services for each category, if I can use that.
Yeah, well, I would say just from a member of the public's perspective, like what is the most common things we do? Relief again of the gender dysphoria specifically. So it's not necessarily like the John Travolta movie Face Off, where you're just like coming in and like coming out a completely different person. A lot of times, I would say 70 plus percent of the times, we are removing breast for dysphoria. Here's the
Okay.
story that I hear often.
Okay.
Um, I knew I had different feelings about my identity, which never really kind of manifested until these breasts came. And then I can't stand looking at myself, and I really am struggling and, have these psychological issues as a result of it. So that would be a female to male transition
Right.
surgery. That would be top surgery called simple mastectomy that we usually do with what's called free nipple grafting. So we essentially remove breast. We close the chest down in a flat orientation, and then we replant the nipples as
Okay.
a graft that then takes as basically sticks to and grows into the tissue, but in a male orientation. So I would say that's probably the most common thing.
Okay.
The reverse of that is male to female transition, where we essentially do breast augmentation. There's nuances to that. We have to account for the differences in the male chest versus the smaller female chest becoming a larger female chest.
Sure.
There's different considerations there, but it's breast augmentation.
Gotcha.
So chest modification is probably the most common just because it's the most prominent in the body and its identification in public as either male or female.
Gotcha.
Um, facial procedures are becoming, I think, more common and more covered, but aren't probably as established. They don't have as long as a track record or history.
Right.
But we will often do things to reduce the bone because there's a thing called Virchow's principle where the muscle attaches to bone. And then if that muscle is active, then it makes that attachment to bone stronger because it needs to be stronger because that muscle is pulling on the bone harder.
Sure.
So there's then bony prominences that are made. So those happen here in the angle of the jaw. They happen in the glabella, where you have prominence in the lower part of your forehead, because this is a frontalis muscle that raises your eyebrow. This is a masseter and other muscles that clench your jaw. So you'll have a rectangular face in a male because of some of the formations of these bony prominences, where you'll have a more rounded, oval, or heart-shaped face in a female.
Okay. Yep.
Once you hear some of these things, it intuitively lands, and you think, "Oh yeah, Scarlett
Yes, sir.
Johansson,"
Yes.
or
Yes.
Emilio Estevez. I mean, there's different facial silhouettes that you can picture that look sort of traditionally male, traditionally female. So that's the common things that we're doing in the face, is reducing those bony prominences in male to female transition, such as forehead reduction, jaw reduction, chin modification, or genioplasty.
Right.
And then some, I think we've all met people where they have a very prominent, strong nose and they're a male and that looks congruent, or a strong nose and they're female and it looks maybe incongruent. These are some of our aesthetic patients, right, that are
Yes.
saying, "Oh, I was born with my dad's nose, so I just want to get this reduced and have more of a button nose or something." So it's the same principle then in gender affirmation. If someone has a very prominent nose that is more downturned, then that's often converted into a smaller nose. Smaller nose is more upturned and reduced size of the tip, perhaps.
Okay.
Also, the lip is typically shorter. Upper lip is typically shorter in a female. The cheeks are typically fuller. So all those modifications, in addition to the trachea, the removal of the prominence of the trachea in male to female transition. In male transition of the face, it's often implants. So it's putting those jaw angle implants in. It's making a more prominent chin. It's sometimes either putting fat or custom implants here in the glabella. Nose can be modified and made more robust if it is something that patient desires. So custom implants are often the case for the face.
Interesting.
For the body, it's usually liposuction, not always. If someone has significant weight loss or some other things in addition to their gender dysphoria, then it can be other things as well. But it's often liposuction and removal. Like if you made an S curve of a body, then you would say, okay, like here, like that's a female form, right?
Sure.
So how would you make an S curve more rectangular? Well, you'd remove a little here and you remove a little here. And then you can put that fat in other places. So for instance, if we're, fat grafting is really just reverse liposuction.
Sure.
So if we're taking out of fat from, say, the anterior and posterior hips to make the hips less prominent, to have less curvature there, and we've done top surgery and we've extended that into the brow roll area, well, all of a sudden we made the body more rectangular. And then if you wanted to have, say, a more prominent glabella, you could have fat grafting to there. And that is both in line with female to male transition surgery.
Gotcha.
So this is where those things that plastic surgeons can do really come into play, because that's our toolbox. That's
we do. Yeah.
Yeah, it's not exactly something that a lot of fields can say they can just rearrange. So yeah.
Absolutely. I'm thinking kind of as the potential client, and I just want to follow up on some of the things that you just expounded on. So it sounds like for a male face, we're trying to get a more rectangular face. For a female face, we're trying to get a more rounded or oval face.
Mm-hmm.
I'm hearing. For men, or to get a more masculine face, you're doing custom implants. So are you talk to us about that? Or is this the generation of kind of 3D printing? Can you expound on the implants, or these are just on the shelf? You order a size, I'm being silly, size 5, and that's what you do.
You can do either way. I like to use 3D planning whenever I can. It
Okay.
is costly.
Okay.
So I think that comes into play in a patient who's deciding if they are paying out of pocket. Not everyone is paying out of pocket, and if that's covered, such as if there's an institutional contract where this has the ability to be utilized, then we usually do.
Okay.
But I think 3D planning is a really advanced tool that just basically takes a CT scan, uploads it into a cloud platform, for lack of a, just to oversimplify it. And basically, in this virtual environment, you work with an engineer and you simulate the surgery and the implant before doing the surgery. And then those things can be converted into transitional elements such as custom cutting guides or custom implants that are actually designed to the topography of an individual specific bone, to like the sub-millimeter
Right.
degree of accuracy. It can also do things like, if we're cutting bone, map out where the nerves that run through bones live so that we can avoid them. Tooth roots, a lot of advanced tools. I mean, eventually that's going to be at the level of, your Ready Player One movie virtual,
Sure.
goggles that you put on in
Right.
the operating room. It's only a matter of time. It's not quite there yet, but people are already trying to experiment with this.
Gotcha.
Um, but yeah,
Gotcha.
we use 3D planning as much as we can. Virtual surgical planning, it's called.
Okay, perfect. I'm gonna brag on you a little bit, but and I'm gonna select you out for the skill set that you have, so my audience can understand. You have that skill set because you did a craniofacial fellowship. You
Yeah.
understand those nuances. I'm not trying to disparage other plastic surgeons, but that is something that maybe you just can't walk into any plastic surgeon's office and get that type of expertise. So Dr. Day is an expert based on his training. He has those understandings of the anatomy and the nuances of those procedures. So I'm going to brag on you just for a second.
Thanks.
Uh, Another question I had, I'm gonna drop down a little bit to chest, maybe more kind of from male to female. And I'm just thinking as a plastic surgeon, just general. You've got a flat chest, you need to get a certain volume. In my experience, trying to do kind of immediate breast reconstructions, I'll use that kind of term, that framework for someone who came in who had a B cup breast, who had breast surgery, had a mastectomy, and wants an immediate reconstruction, and wants to have a D cup breast. I can't do that, and I would stage that with some type of tissue expander.
Yeah.
Uh, my point is, if someone's going from male to female, do you do it
Right.
as a one stage or two stage surgery?
It's a great question because it depends on what the patient wants and it depends on how they're starting out. So we have a bunch of principles that we try to not jettison, but also borrow from, more fundamental, long-standing textbooks and things like that, such as you have to have enough coverage. You have to be able to pinch enough tissue that's going to cover your implant, or else you're going to have exposure and issues at the surface as a result of an implant close to the surface. So we have
Right.
to do I had an interesting revision case recently to that note that, we had to do fat grafting in the envelope before doing an implant exchange and then some internal modification of the capsule. So it presents unique challenges where
Yes.
I have to say, okay, well, I've not done this particular math problem before, but I know this number is 5 and this number is 10, and here's some addition and subtraction signs.
Right.
And so I guess if I rearrange this, then this makes logical sense based on surgical principles. So that's what we did, and that patient did really well. But I totally agree with your thought process. Same direction you're taking, really, because you're referencing it to something that you're doing in breast reconstruction, and that would be the same. So if I had a patient who wanted to be large
Yep.
and was male to female transition, then that might be a two-stage surgery where they actually have to get an implant and then get that implant upsized, or even better is a tissue expander, which some patients can endure and some patients can't,
Sure.
because they, in breast reconstruction, they might be anticipating this, or they might have some residual breast tissue that is still there that you can work with. Sometimes these patients are not of that mindset nor have that breast tissue to work with. So, but all the better if they do a tissue expander, because then you just go up in a stepwise fashion. Yeah.
Yeah, absolutely. Control for me, control is everything. if I can kind of dictate and be predictable, not go up to bat, to use a sports reference, and try to slug a home run and just get on second base every
Yeah.
time, I'm good. My percentages of success are going to probably be good to score for
Yeah.
sure.
Right.
Um, Switching gears just a little bit, and we talked about the procedures and what you do and your expertise. What if somebody is listening to us who's struggling, who has dysphoria, who doesn't know where to go? They don't live in Seattle. They don't live in Atlanta. They live somewhere that's not so populated. What are the steps that they can take to get them on this path? What would you recommend to that client or that patient?
Yeah, in my experience, there's a very grassroots community. There's a strong grassroots community thread that seems to be in any community around them. And so I would first just say, talk to your friend and tap into that.
Okay.
Failing that, or if you just want something that's relatively foolproof, probably anywhere you are, there'd just be two websites that you could quickly go to. One is a WPATH website that I'm
Okay.
sure has contact information, resources that can search through to get guidance. That's an international organization called WPATH, WPATH.
Give me
And
that
then
website. I'm sorry, Kris. I didn't mean to interrupt. Just give me the website. Is it www.wpath?
I believe it's wpath.org, but
Okay.
like anything, I just Google things. So
Okay, so okay, so you can just add that. I'm gonna add that so that our listeners can see it. I believe I spelt that right. So if they can
Yep.
reference that, that's what you're recommending as a resource.
Yeah, I think that's they've sort of identified themselves as the largest and most centralized and most evidence-based organization in the world, really, to not
Okay.
only define the standards of care but be a resource. And then the American Society of Plastic Surgery website is where anybody can find a plastic surgeon that's board certified. So you're not just getting a provider. Sometimes providers say the words board certified, but they're not
Sure.
backed by the national organization that actually creates boards, called NBME, which plastic surgeons are backed by that. So, you're board certified. I'm a double board certified plastic surgeon. We've all been through this rigorous training program, and I think not only does it just have a moniker behind it, but it it enforces a deep thought process between
Okay.
what we're doing, which I hope your viewers have seen in our conversations. We're considering these things at a level of depth that is ultimately designed around the best outcome for the patient at the lowest risk to get them to the greatest transformation and betterment of their lives that we can.
Sure.
So the American Society of Plastic Surgery website can be a place where you can just find a board certified plastic surgeon in your area.
Gotcha. Gotcha. Great resources. What would you say would be some of the challenges that may be confronted by these clients or these patients, and could you speak to those in your experience or
Yeah, I've gotten exposed to it a little bit. So I probably introduced something that maybe is a little mind blowing for people listening. Maybe I it was a little bit for me when I realized it, and I didn't realize it until months after I started doing this care. But in plastic surgery, we're doing all sorts of things, head to toe, surface of adults, children. We're modifying bone, soft tissue, skin, arms, legs, hands, faces. In all of it, at the end of the day, and I say this as someone who strongly believes in, I'm happy to completely commit my, the majority of my waking hours to doing this work for the rest of my life, right? So I'm not saying this as a dissent. I'm not dissenting,
sure.
but most of it's not life saving. As life optimizing as it is, and as wonderful as that is, you know, we it's almost unconscionable to think this way, but if you didn't do breast reconstruction after breast cancer, you just wouldn't have breasts.
Yeah,
If
sure.
if you didn't do limb reconstruction after trauma, you might not have a limb, but you'd still be alive. Some of these patients are just debilitating level of depressed and have had multiple suicide attempts. So
Yeah.
I feel very comfortable, I guess, having seen that in real life and kind of been put in the position, again, this chose and found me, of that type of allyship to speak out on these topics because I've seen it.
Okay.
But to the point that you're making, I think it's access. So I'll give you an example of why I gave you that long soliloquy leading up to your question. Just a week ago, on Monday, I'm doing a top surgery on a 16-year-old. It's controversial.
Yes.
It's risky.
Yeah.
It's not something I don't advertise for this.
Sure.
I was sent this patient from a local world-renowned children's hospital.
Interesting.
Just due to the fact that their waiting list is prohibitively long. So some patients I find now more and more are wanting to undergo their transformations like before going to college, or trying to not endure all of high school.
Yes.
In their dysphoria. So I do some additional things for that. So I go kind of beyond the minimums. I get two different verification letters. I do require conversation with both parents. There's a thing called consent, and then there's this thing called assent. So a minor can't consent to surgery; they can assent to surgery, but it's really the parents that are consenting to surgery. So we do some additional documentation of that. I have some frank conversations. I personally must be involved in saying, are you sure about this is the rest of your life?
Yes.
And
yes.
and is that something that you're seeking? And
I don't mean to interrupt. Does that cause you an existential crisis personally?
Yeah.
Oh, yeah. Okay. All right. Because I'm just getting nervous just thinking about it. And I've had some of these conversations with, breast reduction patients. But again, to me, that's another level, a different level. But I would have an existential crisis with this
all the time. I am a white heterosexual father of 3 from a town of 6 stoplights in Seattle, Washington, doing gender affirmation surgery. I mean, if you don't think
but I get you.
I have existential crisis on the way to work. I mean, it's just how it is. I mean, I've had landlords who's asked me questions about my practice. I've had so this patient was referred to an imaging partner that we have 800 feet from our office, that we send all of our preoperative chest imaging patients, because breast screening is something that we follow, even though that's a conversation that's now happening on bigger studies. But we do it routinely. And this imaging partner refused the patient because they said, we don't do preoperative screening on minors, and just turned them away. If enough people turn people away, eventually you don't get that care. Now, why did I lead with all that, cancer conversation? Would you ever experience that in breast cancer?
No,
unconscionable.
Never.
It would be,
yes.
It would like make the news.
It would make the 5 o'clock news. Yes, exactly. That's my point. It would make the 5 o'clock news just before you can even blink an eye.
Yeah,
absolutely.
And now all this is said is I'm your listeners probably think like I'm a really political person now. I try not to be. Sure. I'm fairly apolitical, or I try to be, because it just doesn't serve me to get too caught up in some of the tirades. But I will say, like, when our patients encounter this, and they do encounter it, and then you have side questions asked. So doing surgery in some places,
yes, I imagine,
you will get a lot of kind of passive aggressive, microaggression type of questions that, again, would just never be asked of a cancer patient, because it would be inappropriate. But in this realm, you see it almost routinely. So, as a provider of something that I didn't necessarily set out to crusade on, but I'm happy to participate in care that gets people that keep telling me they are better, they're feeling better about themselves, I'm happy to do. So, it's a conundrum, though. And I think it's one that's not just faced by our office, or not just faced by some of these patients who've had, tremendous journeys and struggles they can tell you all kinds of things about. but also, society overall. And, those are conversations really that happen way over my head. And I think they're going to be ongoing because I don't think this is going away. I think this is something that, if it's really embraced, has multiple next levels that it can go to. Or if it's not, then that's also a decision that's going to be made by people, way bigger than me. But yeah, it's interesting. It's interesting to just be, I guess, part of such a dynamic and evolving and somewhat thought-provoking process with people.
Absolutely. You're at the forefront of this. You're pioneering, and I'm going to just say, I'm on behalf of anybody with gender dysphoria, any of your patients that have successfully and cheerfully had their outcomes. Thank you. I mean, thank you for having the courage to do that and being a refuge for clients who need this type of care. So you're a pioneer, and your courage is admirable. So that's for me.
Well, thanks, Earl, but I don't know if I don't know if I deserve all that, but yeah,
I'm gonna give it to you because I think you do.
we all follow leadership of, I don't even always appreciate the things that I'm learning until maybe 6 months later, and you've applied them yourself, and then you think, oh wow, I wouldn't have known that if it wasn't for this person or that person. And
Sure.
man, I have half a dozen mentors at any one stage of life. Like every day I have a spectrum of half a dozen mentors, and you're one of them. And I'm only capable of doing any stuff because I've learned a lot of stuff from a lot of other people. So yeah, but thanks.
Yeah, of course, it's great to have a good community, I'm glad to be a mentor and be a resource if I can, anytime I can. All right, so let's do this. This has been great. I've learned a lot. I hope my listeners have learned a lot. Let's talk a little bit about what you see the future of gender affirming surgery. Is there a trajectory that you're anticipating, predicting? What are your thoughts?
Yeah, I'm hesitating because I do try not to engage in the political.
Yes,
However, I think it's almost impossible to answer that question without acknowledging the elephant in the room.
sure.
So, come last November, we had multiple patients reach out to our office and say, "Can I get in right away because I need to do this before mid-January," basically.
Sure.
And I don't think that's probably going to be so cut and dry.
Okay.
But this is almost like the conversation about stem cells in the 90s. I actually
Yes.
worked I actually worked in a stem cell lab when that was
Oh,
happening.
okay.
It
Okay.
was an adult mesenchymal stem cell. I don't know why it is that I'm a lightning rod for these things,
It is
but
your purpose, my friend, and path in life. We need
I
you.
mean, my own, stem cells are circulating through some lab because I made $200 donating my bone marrow back in college while I was riding my bike back and forth to the stem cell lab. But
Right.
because it was an adult mesenchymal stem cell lab and not an embryologic stem cell lab, it flourished.
Right.
If it was just the other way around, it would have been shut down. So you're talking about like hundreds and hundreds of thousands of dollars of government funding going to this lab that was doing things that was getting the attention of some of the highest scientific minds in the country, but only because it was adult mesenchymal stem cell labs, right?
Right.
If it was embryologic, which has some greater potential
Sure.
scientifically, but that decision was made, no, that's not going to happen, and it literally would have been shut down, right?
All right.
So I think gender affirming care is probably approaching some degree of a, a precipice that has to be negotiated in a few different directions. It can kind of stay as it is now, where there's good conscientious providers out there that's maybe not in a really solidified network and system but are just trying to do the best they can for the patients that come to them on a case by case basis and in concert with other providers in a framework like WPATH.
You're right.
Then there's we can't do it anymore. Okay. In plastic surgery, we straddle this world of plastic and reconstructive where we are doing some things that are covered by insurance, which can be governed. And we're doing some things that are not like out-of-pocket surgery, as long as we are doing standard of care to the best interests of our patients with conscientiousness in mind and following like standards such as WPATH, then we can actually do surgery even if it's not covered by insurance. And we do that all the time with eyelid lift, blepharoplasty, where there's extra skin, but it doesn't cover the vision enough per the test. So we do it as an aesthetic procedure or things of that nature. So that's a direction that things can go.
Okay.
Or, there's a lot of, among the initiates within the community, there's a lot higher level of cohesiveness of care that people think that can be achieved, and basically saving individuals from going through any more time in their dysphoria than they have to. If you think of it this way, and your listeners who haven't been exposed to this are going to think this is pretty controversial, but those who have been exposed to it have probably heard this before. Hormone therapy started at the age of 18 after you've already been exposed to hormone therapy through your own biology,
right,
for the last 6 to 10 years, that has changed your body. It's kind of like, hey, the horse is already out of the barn.
right.
Why didn't we do this years ago? Right.
Gotcha.
So if you are that patient who is very sure about their own identity, they have a support structure, they have parental involvement, they have all of the elements that one would expect to have to make these forever decisions, then there's a much higher level of care than we're probably capable of in instituting hormone therapy earlier, orchestrating stage surgeries in a sequential fashion that makes sense, some of which happens in a case-by-case basis by nature. But I think in the times that it does, it's happening due to just the tremendous steam burned by patients that are self-advocating and accessing various organizations that are helping them navigate through piecemeal systems right now. Right. So I think there could be a lot more cohesive orchestration and earlier application that may be the direction things go, if that's where the environment allows it to develop.
Gotcha. Yeah. Well, I guess the old adage, time will tell with the new powers that be. They'll be malleable as practitioners to serve the needs of our patients. And I think that's probably what will happen as an overarching theme.
Absolutely.
Kris, this has been great. I've learned a lot.
Thanks.
And I appreciate you. I appreciate your time. I really do. I know you're busy. I appreciate your time. Any closing thoughts, comments that we didn't touch on or I didn't ask that you want to convey?
I just want to share two things.
Okay.
In medical school, a Mayo-trained internal medicine doctor, family medicine doctor, I believe, came to our school, and as an enrichment lecture, you didn't have to go to. He talked to us, about his decision to go serve it was a kind of a more fundamental Christian community, Mennonite, that didn't have various technologies, but they also didn't have access to healthcare because there weren't doctors living there.
Okay.
And he told about how he never planned to do that. But he set up his practice, and it was in a certain proximity, and the elders came and asked him, would you help us? And so he did. And his guiding principle was basically serving the needs of the patients in the community, So that's the thing that I've been exposed to. The other thing, Earl, this is really taking it to more of a lightning rod thing, which again is unfortunately what I tend to do.
You are.
So in, I believe it's elementary school, there's a town, I believe it was Salem, Iowa, that had a underground railroad house. And I don't know if it was a question posed directly to me or if it was one that just kind of like came into my head at that time. But they took us in this house because it's a tribute place to when slaves were taken from the South to the North.
Yes.
And there was a hole in the floor of the kitchen, and it was like where people were hid. And the question that came into my mind, or the one that was posed by the teacher, was, imagine you're living in the 100 years ago. Would you have the courage to do that? And I never thought I'd actually be exposed to anything that was close to that.
Sure.
But I mean, and maybe it's wrong of me, especially as a white guy, to make these comparisons, but in 2024, what group is more prohibited maybe from pursuing the things that they feel is right to them? And would you have the courage to be part of that? So
sure, absolutely.
I mean, these things do trickle into my head as I kind of search for reason and meaning and what I'm doing, as these things kind of keep finding me more and more. So those would be the only thoughts that I would share as final parting. Unless we haven't talking about enough controversial things that I would just throw out there to make it even more controversial. Make
that podcast more interesting. But I mean, we could talk all day, but I really do appreciate it. And that's a great, your story as a 6-year-old is really touching, and understanding that, this group they have the courage, but people like you, like back then, who could see the future and see the betterment of man and help humanity, and were put there to do so. That's you. You're helping these people have the courage that there's hope and there's a future. So again, I just want to thank you for being there, available, and offering your services to better humanity.
I mean, you're probably being a little too excessive again in your praise, but I do thank you for that. But I mean, I guess what it boils down to for me is, given the choice, like, we don't know. I don't know. It's 2024. What's 2030 going to look like? What's 2040 going to look like? I don't know. It could be that we look back on this time and say, oh, we were wrong. Disco wasn't it.
Right.
We needed to move on from that,
Right.
and that could be the way we look back at this. Or we could look back at this and say, gosh, I mean, hey, this had to start somewhere, and it wasn't ever going to reach a certain threshold until there were enough people participating in it that it became a conversation, that it then really had traction to get more organized. And these are just the start. I don't know. But at the end of the day, I guess the principle I just rest on is service.
Sure.
If you're serving patients, and the patients come first, second, third, and last, I think you can rarely be completely wrong. So
I agree with that. I mean, I'm gonna break that down even simpler for me. I have certain gifts, and I'm going to share those gifts for the betterment of others. So that's my mantra.
And you do it all the time. You do it all the time, and then you tell people about it, and that's good. People should listen to you because you're one of the more down to earth and honest voices out there. There's a lot of craziness going out there in the in the metasphere. So listen to Earl.
I appreciate that. Thank you, Kris. And on that note, I really appreciate, again, your participation today. I've learned a lot. Hopefully my viewers have learned a lot. If you guys are anywhere in the country, hey, we live in a global society now. We don't have barriers of geography. If you're interested, give Dr. Day's office a call. It's his number. He's in Seattle, Metro Seattle. It's 425-818-8991. The name of his practice is Pacific Sound Plastic Surgery. So you have questions, certainly do that. If you don't want to do that and you're a little bit more introverted, and you want to just kind of creep around a little bit and just kind of do a little bit of soul searching and on your own time, you can certainly get on his website, www.krisdayplasticsurgery.com. And with that, Kris, thank you so much for your time. Blessings to your family, to your practice, and what you do for humanity again. Take care.
Thank you, Earl. This was so fun. Appreciate it.
Perfect.